Hi, hello everyone. Welcome to the first webinar series of Medical Humanities. And this really has been an exciting journey for us, and we started this off in 2019 with the inaugural Night to Remember, if you all have attended it. Okay, and then subsequently we went on to screen videos related to tuberculosis, for example, and we even had readings by Prof. Wu. And today is our very first inaugural series where we would like to tackle some of the important issues in medical humanities. Today we'll be talking about inequality in Singapore. And with me, I'm very much pleasure and honor to have two very important local guests with me today. So I'll invite, I'll first introduce Dr. Lim Sufi. So she's a Deputy Director of Nursing of APNs, and is a specialist nurse in rehab medication and RHS community nursing. So she did her training in rehabilitation in many well-renowned institutes, for example, the Institute of Chicago, the Michael E. DeBricke Veterans Affairs Medical Center in Houston, as well as the Durham Veterans Affairs Medical Center and Duke University School of Nursing in Durham as well. And she's now currently actively leading a team of community nurses in providing care to residents residing within the SingHealth Southeast communities of care. And so without much further ado, Dr. Lim, the stage is yours.
Thank you. A very good afternoon to everyone. So it's a privilege to be invited to have this session with all of you. So before I start, I thought it would be good for me to provide a little bit of background about myself. So after graduating in 1992 as a registered nurse, I worked in the rehabilitation wards and also in the training and development unit before becoming a specialty nurse in rehabilitation medicine in 2003. So I was in the rehabilitation medicine ward for 15 years before being tasked to lead the SingHealth Southeast RHS-led community nursing program. And that was in February 2008. So the RHS-led community nursing was established in February 2008 to anchor population health and also to facilitate the shift of care beyond hospital to the community. So what do? We provide the community nursing consults at the various community nurse posts, which are located within our 5 COCs. We also reach out extensively to our social and healthcare partners in the community to leverage on their strength through capability building and also strong partnerships. So our model of care is geographically based, and we provide services to residents who are residing within the 5 COCs, regardless of which hospitals or doctors they visit. Now, when we first started out, we had to engage many of our institution colleagues and also community partners. And we were often asked, what types of patients or residents can we refer to you? So we will say those aged 60 and above with 3 or more chronic diseases and those require assistance to manage their chronic conditions. But many of our community partners, they are non-healthcare workers. So they do not know whether the person has chronic diseases or not. But what they do know is there are at times it worries them when they leave some resident's house after the home visits or after the residents leave their centers. And I often joke with our ED colleagues that if they encounter patients who are not too sick to be admitted, and yet upon sending them home, it worries them and makes them feel uneasy. So do refer these patients to us. Now, as healthcare professionals, we always worry about our patients. We worry when they are admitted, and for some patients, we also worry when they are being discharged because we are not very sure whether they will continue to follow the recommended treatment plan, whether they will continue to respond well to the medication that we prescribe, or whether they will continue with their exercises. So these are our worries. So what about the worries of Singaporeans at large? Now, there's an interesting survey was done this year on 913 Singapore citizens, aged 18 to 64 years old, asking them about which 3 of the following topics do they find most worrying in Singapore. And the top areas of concerns, as you can see here, were the job markets and unemployment at 48%. Now, which is understandable. Healthcare at 42%, equally understandable, but guess what? Poverty and social inequality at 33%. So it is interesting to note of Singapore's concern for poverty and social inequality. And I think this is somewhat a valid concern, as while most of us know that Singapore has one of the highest per capita income in the world, there is still a significant proportion of those who are vulnerable. And there are nearly 20% of households who have a monthly household income of less than 2,000. Now, when thinking about opportunities in general, Singaporeans say there is some inequality according to different demographics of the population. 38% of Singaporeans feel that most inequality is experienced by people with disabilities, and 29% say inequality is most apparent between social classes. On government subsidies, most Singaporeans feel that the ideal scenario will be where low-income groups receive more government subsidies than high-income groups. Now, let us have a look closer to home, which is our SingHealth population landscape. Now, as you can see here, there are three distinct demographic differences within our three sites at the southeast, east, and the northeast. Focusing on the southeast, although it has the smallest proportion of population, as you can see here, the number of seniors aged 60 and above are high at 27% as compared to the east at 23% and northeast at 13%. The number of people living in one or two room flats are also high at 12%. So similarly, in comparing with the national resident population, as you can see here, the southeast side has the highest percentage of those aged 60 and above, which is shaded in brown. See here. And also those living in rental flat shading in pink. You can see the southeast side has a large proportion, about 10%, compared to the northeast and the east at 3%. Now looking at another data, you can see Southeast also has the highest percentage in terms of those with 4 risks, as highlighted in red at 5%, those living alone, as well as those requiring financial assistance. So by and large, the Southeast side generally have a larger proportion of the elderly living alone, staying rental flats, and requiring financial assistance. For the disability group, all the three sites are similar. So Singapore is being known as an affluent society, to have a very vibrant kind of adaptive knowledge-based economy, which produces much opportunities for employment and social mobility. So does inequality occur in Singapore? And the answer is yes. So in fact, inequality was mentioned as one of the most serious issues facing Singapore today, in addition to aging. As mentioned by our Home Affairs and Law Minister, K. Shanmugam, that Singapore has done relatively well in reducing inequality over the years through multiple lines of assistance. More has to be done. Now, let us have some understanding on equality and equity first. So now, while the terms equality and equity may sound similar, the implementation of one versus the other can lead to dramatically different outcomes, especially for marginalized people. Now, equality means each individual or group of people is given the same resources or opportunities, whereas equity recognizes that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. Now, this means that the amount of resources and opportunities given are depending on respective needs. Have a look at the illustration below. As you can see, the two individuals on the first picture, the two individuals have unequal access to a system, in this case, the tree that provides fruit. And the person on the left has abundance of fruits as compared to the other person on the right. With equal support, now look at the picture number 2, with equal support from evenly distributed tools, the distributed tools, which is the ladder, the access to the fruit still remains unequal. As you can see, the person on the right still can't reach the fruit. So the equitable solution, which is the third pick, allocates the exact resources that each person needs to access the food, leading to a positive outcomes for both individuals. So in this case, a higher ladder. So while the tree appears to be a naturally occurring system, it's critical for us to remember that social systems are not naturally inequitable. They may be intentionally designed to reward specific demographics for so long that the system's outcome may appear unintentional. So equity is the solution for addressing imbalanced social systems. And lastly, justice can take equity one step further by fixing the system in a way that leads to long-term, sustainable, equitable access for more generations to come. So in this case, as you can see on the picture on the extreme right, knowing that the tree is slanted towards one side and has more fruits, it gets adjusted so that both parties have equal opportunities to the fruit. But for today, we will just focus on equality. Now, I was very privileged to attend a speaking engagement series webinar by the Minister K. Shanmugam last month, and I wish to share some insights from the session. Now, he shared that creating an uplifting society, in recognition that there's a wide equality in Singapore. I mentioned in the context of three aspects: income, demographic, and geography. Now, for income, there is this middle income group in Singapore which has been moving very fast. So we have got very high level of middle income. It's about like 20% higher than the US, 30% higher than Sweden and Finland. So Singapore has a high level of middle incomes, and this creates a wider gap for the lower income group. And so not just the rich is doing well, but the middle income group is also doing very well in Singapore. Next is the demographic. So the economy remains a source of wide link between equality between the segment of old population and younger population. So if we have a look at the lower 10% of our wages, there are more than 50% age 55 and 45% above 55, and most have received limited education. In geography-wise, Singapore being in Asia, in a region where income are much more lower for majority of people, we have a large supply of the less skilled worker. So he cited mitigating income inequality, ensuring the social mobility, and enhancing the social integration was identified as critical in creating an uplifting society. So some strategies were recommended, but due to time constraint, I would just want to particularly focus on one, which is the extending through life, which is applicable to us. So the take-home message for me for his session was that company, society, government, and community, we should support lifelong learning. And as employers, we could collaborate with each other in a tertiary education, provide on-the-job training and internship. Now take some responsibilities to upskill and reskill employees, to develop them at work with mentors. So we need mentors, and learning at work is actually very critical. And in employment, we should not expect people who come out of school to be competent to do the job. In fact, we should focus on readiness to learn and not ready-made to work. And in particularly, and most importantly, we need to pay more attention to the older group through work fair, subsidized training, help them to keep jobs and preserve the sense of self-respect, being at work and also contributing. So, is inequality also evident in relation to health? For example, disease prevention strategies, which seem to have a greater impact on more influenced social groups. Is it true? And is there a health gap between those who have and those who have not? And also, do people from disadvantaged groups are more likely to have problems accessing health services? So, in a parliamentary Q&A highlights in May this year, there were also questions put forth by an MP to the Minister of Health on how does the ministry measure health inequalities in Singapore, and whether Singapore has made progress in tackling the health inequalities. So based on the written reply, which I extracted, which was mentioned, it seems that persons in the lower socio-economic group with chronic diseases, now they are using the educational levels as a proxy for socio-economic status. So those people in the lower socio-economic group with chronic diseases have good access generally have good access to healthcare services and healthcare outcomes. And among Singaporeans with primary education and below who have chronic conditions like diabetes, hypertension, and high cholesterol, more than 90% had visited their doctor in the previous year for their condition, and they also had comparable disease outcome as compared with better educated Singaporeans in managing their blood sugar and cholesterol, although less so for the blood pressure control. And individuals can achieve good health outcomes by taking charge of their health, seeking timely intervention, and adopting healthy lifestyles, which we agree totally. And MOH facilitates this by reducing cost barrier to healthcare. For example, as we know, on health screening, subsidies under the Screen for Life were enhanced in September 2017, and under this revised scheme, the final generation pays $0 for screening, whereas those people who hold the CHAS Blue or Orange card, and also the Medica generation, pay only $2, whereas the rest of us pay $5. And this payment covers screening tests, doctor's consultation, as well as the first follow-up consultation at the CHAS GP clinic. So, and MOH has committed to continue to monitor the health equalities and put in place measures to ensure that all Singaporeans have access to quality and timely healthcare. So, what can we do as healthcare workers to tackle health equality? So there was a proposed agenda for action which focuses on 4 areas: strengthening individuals, strengthening communities, improve access to essential facilities and services, as well as encouraging macroeconomic and cultural change. Now, each of these areas addresses some key factors which are thought to be antecedents of the health inequalities. So, namely, number 1, it seems that there are facets in an individual's natural or natural cultural makeup that influence their susceptibility and predisposition to disease and illness. And the communities in which people live will either mitigate or aggravate their health experiences, such as environment factors and also social resources. This could offset the stresses of life a person experiences. And also the ability of the person to utilize health services can effectively, affect or influence their health outcomes. And this can come in terms of prevention and treatment. And also there are structural forces such as relative and absolutely economic disadvantages that are fundamental to a person's experience of health. So not just an individual's motivation. So to enhance access to health services, it was recommended that there is a need to establish partnership with local community development workers based in the community. Firstly, to help the local people access health services and provide opportunities for health screening and education. And lastly, and most importantly, to establish an effective and meaningful relationship with the local community. Now, the third aim reflected the team's aspiration to become more rooted in the daily business of the community. So, for example, acting in the community rather than on it, be part of the neighborhood. So, being part of the neighborhood is also the way the model of the RHS-led community nursing is embracing. So in order to establish an effective and meaningful relationship with the local community, we strategically cited our nurses and most of our community nurse posts at the senior activity centers, which is also where the rental flats are. And we feel that this allows us to work very closely with our community partners by being there, being accessible, and being part of them in the neighborhood. And our services are fully subsidized, meaning that the residents do not need to pay out of their pocket. So to date, we have about 31 community nurse posts within the Southeast Zone. Now next, I would like to share a few stories on what I call missed opportunities to better health. These individuals, for reasons of either disadvantaged family background, poor health condition, physical or mental challenges, or perhaps misfortune, they were unable to access or less able to access available opportunities leading to better health for them. So perhaps in community nursing, we get to have more encounters with this group as compared to other colleagues in the hospital. And many complex cases that we see have very challenging circumstances, which makes their maintenance of health very, very challenging. So this is Mr. M. He had been rough sleeping in a swimming complex for 1 month due to estranged relationship with his family members, and he had defaulted all his appointments, ran out of medication for his chronic condition, and running out of cash and food, he purchased biscuits high in sugar content to satisfy his hunger. So that makes his condition worse. Now, for those of you who are new to this group of homeless people, here are some facts. In fact, I also just got to know them last year from one of my community nurses, Chen Yu, and her husband founded the Homeless Heart Service. And we have got a lot to learn from this young couple. So here are some facts. So there are between 921 and 1,050 homeless people in Singapore, and they are geographically widespread with significant variation in numbers across districts. Majority of them are older men with irregular work and low pay, and mostly Singaporean citizens who are either single, separated, divorced, or widowed, and had low education. And they present in very diverse ways that are not consistent with the stereotypes of vagrancy and destitution. And most of them have poor health and nutrition. 3 main reasons has been identified for their homelessness status, which are insecure work and poverty, family relationship problems, inadequate or inaccessible housing services. Now you can see the link here between employment, poverty, which then affects the relationship. Accessible to housing services also plays a role here. Another case, Mr. T, 70 years old, who visited a doctor at the SOC and was scheduled for colonoscopy. He was briefed on bowel preparation by the clinic nurse, and because before he left the clinic and nearer to the colonoscopy date, he cannot remember the instructions and who to call, and he does not have a smartphone or data plan, and he does not qualify for Telehealth VC. 2 other cases with very similar background or context. Mr. N, 36 years old, is wheelchair bound due to an accident sustained 2 years ago. Used to be very active in sports and goes to the gym often before his injuries, but now he has been cooking himself at home. And Mr. N, 65 years old, wheelchair bound, is dependent on his elderly partner to mobilize him outside his house. So without his partner, he will not be able to get out of his house. Even with his partners is actually quite reluctant to bring him out because of inconvenience. And he has not been going for his medical appointments and has not been taking his medication. Now, sharing the prevalence rate of the people with disabilities in Singapore in accordance to different population groups. As you can see, the student population and those below 50 years old, about 2 to 3%. 50 years and above, you can see is higher, 13.3% of the resident population. Now, although Singapore has progressed well in terms of being an inclusive society, there are still some barriers, for example, in terms of sports. It was found that only about 1/3 of the patients with disabilities participated in sports on a regular basis, which means at least once a week. And some of them needed modified physical education and sports program in schools to be able to participate. However, inclusive or adapted physical education and disability sports program remain a relatively new area in most schools in Singapore. And there are also inaccessible fitness facilities and health clubs, programs and equipments which are specific for people with disabilities, as well as the challenges of high program costs and also lack of transportation. So, from the data and the many stories presented and encountered in the community, we know that number 1, social and economic factors have a great influence on health as compared to clinical care. So social needs contribute to higher healthcare costs, and also having a social need leads to poorer health. And also based on a local study, there is also an association between public rental housing, readmission fees, and also increased utilization of hospital services. So one's health is perhaps shaped not just by personal motivation and genetic makeup, although we know that personal factors are important too, yeah? So in fact, the environment we live in and the people we interact with all exert profound influence on our health. So the question is, are social determinants matter too? And as we know that not all people are at the same starting point in the race for health. So as healthcare workers, given the well-described health effects of social needs, we have to ask ourselves this question: should we screen every patient for social determinants then? We are often faced with deciding whether we should screen our patient or for social needs. And also, what evidence do we need before recommending routine screening for social determinants of health? Now, we need to take note, the absence of evidence of benefit is not evidence that benefit is absent, so it's different. And conversely, some of the healthcare professionals' time included us with patient is limited. And so we can only focus on efforts that clearly have been shown to improve patient health and well-being. So what is really needed before we recommend routine screening? We need an accurate screening test to identify patients with social need. We need an effective treatment to address social need once identified, because in some cases, we know that screening identifies those with a need, but often we do not know what to do after we identify the need. And lastly, we also need evidence demonstrating that a meaningful health outcome improvement exists before we decide to screen. So I think a more reasonable approach may be to practice case finding instead. And this entails asking about or assessing social needs when a concern is apparent, but not asking every patient about every social determinant of health. And social needs may also surface when we take a history from patient. There are specific signs and symptoms may hint to us that the patient has a social need. So I think as healthcare professionals, our knowledge of the community we serve may also suggest that certain groups of patients are at greater risk of certain issues. So it's good to know that understanding a patient's social needs can also be part of getting to know our patient. But I think what is most important is that when social needs are identified, there must be actions to help, to identify the local resources that can help them. So it's important to establish collaborative partnerships with community partners and organizations to care for those with recurring social needs in our patient population, and this cannot be emphasized enough. So to make the story complete, here is the part 2 of Mr. N. When he was first founded by the befrienders, they checked on his insulin and medication, because of befrienders some are healthcare professionals. So they checked on Mr. M's insulin and medication, and they noticed that he has got multiple chronic conditions. So subsequently, he was referred to the SGH community nurse post for assessment. But before that, they spoke to us whether we can accommodate this group of people, and of course we said yes. So he was found to be in hyperglycemic state, very high blood sugar due to non-compliance, and he was sent to SGH to receive medical care. So he was admitted, and upon his discharge, he was temporarily placed in a safe, sound sleeping place while waiting for long-term accommodation. So our SGH com nurses continue to manage his chronic conditions, and we work very closely with the medical social worker for his social and financial needs. Defenders continue to support him by accompanying him to his appointments, medical appointments, as well as the family service center appointments. And after several months, he finally got his own place to stay in a senior group home. For those who are not very familiar with the senior group home, it's an assisted living model, which the resident can co-reside independently in the HDB rental flat. And all these flats are retrofitted with elderly-friendly features. So after he got his own place, and due to the relocation, his medical care was transferred to NUH community nursing team, and also his social needs were well taken care of by the Alliance Befriender Cluster Support. And eventually, he reconciled with his family members and compliant to all his medication and medical follow-up. So in this case, you can see what he really needs, just a little bit of help and some awareness. These are some sharing some of the housing pathways or options available for the homeless, ranging from short term to long term, so that you are aware, just in case you come across some homeless people that needed housing services. And these are some of the agencies and government bodies that provide assistance to homeless people. There is also this network called the Partners Engaging and Empowering Rough Sleepers, formed by MSF in 2017. And today it's made up of 26 public and social service agencies and community groups. So this network manages the shelters and provides social intervention for the homeless. For Mr. T, he was followed up by our community nurses, and we are proud to say that he was the first resident to embark on our telehealth pilot. So in this pilot, a loan tablet was dispatched to his home, whereby he could consult our nurses through VC on his health conditions and also on his preparation for his colonoscopy. And he was subsequently linked up for the mobile access scheme to our Y-Up project. So these are some of the mobile schemes available for seniors, the mobile access for seniors and Go Digital mobile plan. So these schemes offer very much subsidized mobile data plan as phone sets. Now, as healthcare professionals, we play a diverse role in society, often bridging individual and community perspectives. And we can all agree that advocacy is a core component of our professionalism. It is much more easier for us to be the patient's advocate because we have access to evidence regarding what works to improve their health and also what types of community resources and assistance schemes are available. So for people with disabilities, there are many barriers which strongly influence their mobility, also influence their access to health services and interaction with people and environment. So as healthcare professionals, we are in a position where we can have this unique opportunity to observe and also influence their adaptations to life. So by listening carefully, we can hear their concerns to be able to effectively advocate for their health and also social needs. Sharing some of the acts, the assistance schemes that are applicable for people with disabilities so that we can be their advocate. So this is the Mental Capacity Act, which allows people with mental capacity to appoint proxy and also protect their interests. And I would like to particularly mention about this Environmental Public Health Act and also the Rapid Transit System Regulation Act, which permits guide dogs into the food establishment, toilets, and also into our public transport, and this is very useful. There are various schemes for constructions of accessible features and modification. There are also schemes for assistive devices and technology, transport subsidies, and car park labels to allow driver or passenger with disabilities to park at accessible lots, whether it's in a HDB car park or in the public car park, and also to embark safely. And interestingly, there is also this scheme called the Appropriate Adult Scheme, where assistance is provided to people with intellectual or mental disability required to give statement to the police during investigation. For public transport assistance, they are also available in terms of the train bus captain, MRT staff to assist the wheelchair passengers, free bus ride, taxis. Nowadays, they will also have taxis which can accommodate high back wheelchair as compared to many years ago. We have to book ambulance for patients requiring high back wheelchair. There are also mobile and web systems for free rides and also communication. So there are some infrastructures in the MRT which are purposefully built for people with disability to make sure that they have got opportunities for better access. So for example, accessible elevator and also the wheelchair accessible train, although it's limited to 2 in each train. If for those of you who are taking MRT, after this session, you may want to pay more attention to the MRT train if you are taking train. So they're limited to 2 in each train. So thought that more can be done. For example, more carriages with clearer visibility, and also the lift for people with wheelchair to be more centralized rather than at the far end. Also, there are also color-coded directions, tactile ground surface, and audio announcement for the visually impaired. There are also barrier-free entrance, and also if you notice some flashing red door closing and the lights for the hearing impairment. Some other features or infrastructures, as you can see, but I particularly want to highlight there's this MRT Active Food Mat, and also the vacuum fluorescent display, as well as the practice, what we call, which are very useful for people with hearing impairment. So if you happen to take the MRT, to take note of all this. Yeah. And also, surprisingly, we also have what we call the Disability Sports Master Plan. So in January 2015, the MCCY convened an interagency committee for disability sports to raise awareness and also participation in disability sports for greater inclusiveness and understanding of people with disabilities through disability sports. So they identified 9 key barriers and also put forth 18 recommendations. So this is my last slide, and I hope that my sharing helps in some ways that could influence the way you view inequality, and also as healthcare professionals, how we can advocate for the patients and residents under our care. Thank you very much.
Many thanks, Dr. Lim, for the very insightful talk. I learned personally, I learned quite a few things, because I never knew that we actually went out to buy people phones and teach them how to use laptops and all that. Yeah, so that was really good. I think we have some time, so maybe I'll just sort of take one of the questions that asked. Is there any overlap between sort of what you are doing in Home Nursing Foundation, and then if there is, how do you all sort of split the work?
Okay, so our model of care, or the way we operate, is really leveraging on what is strong in the community. So H&F has been in the community for a long time, and there are different scope of practices. So for community nursing, our focus is more on population health. Okay, and I do believe H&F also has some case management going on. So so we did collaborate, and so if, let's say, the patients, the residents have more of a chronic disease management requiring assistance for follow-up or maintenance, they can refer to us. Whereas for the Home Nursing Foundation, if, let's say, the residents have certain procedures that need to be done and requires maybe like long-term care, more than 2 weeks of procedure, because for their service is based on means testing, so it's a chargeable service, whereas ours is fully subsidized. So we have to be a bit careful in how we provide our services. And so in summary, ours is more on population health.
Okay. And I mean, from us, let's say in the hospital or in the outpatient setting, how do we actually get the patients to see you? Is it through the social worker, or is there a contact point where we can refer directly?
Yeah, so we receive referrals from all sources. It can be from institutions, can be members of the public. The resident can even walk in, but because of the COVID-19 situation now, they can't walk in, and they have to make appointment to see us. So we do have a referral form that enables any members of public or our colleagues to refer residents who requiring chronic disease management or follow-up to refer to us. And we are happy to have closer collaboration. So we also collaborate with our colleagues in the hospital. So with this closer collaboration, it allows us to have more of like a two-way communication. Yeah.
I think just in interest of time, just one last question. Someone actually asked, can healthcare workers who are not doctors or nurses actually volunteer to help out?
Yes. So we encourage, whether you are healthcare workers or not, to join us because basically there are a lot of residents out there requiring a lot of assistance. For example, we need people to help to bring the loan tablets over to them, and now we are embarking on virtual health education, meaning that we are able to give health talks virtually. And even those residents who are at home, who are not able to come to the SACs, or other centers, if the volunteers are able to bring the tablets to them, they can actually join the virtual health education talk.
Yeah, so I think this is something very meaningful, and some food for thought. I think in the residency program, when we are looking for projects to help out in the community, I think this is something that's worth looking into.